all the way from the Horn of Africa, very close to the Horn of Africa. When I say the Horn of Africa, I don't know how many of you really understand what I'm talking about. They are not from, but very close to the Horn of Africa. Is the brand manager or brands manager for a product you are quite familiar with. And I believe that most of you have a very good experience with this particular product, Jardians. And then we've also heard of Trajenta. This gentleman has a very Herculean task to manage this brand. Is a person of Mr. George Courier. He came with another person also called James, but I will invite George to officially introduce George and then also tell us why we are here this evening, after which I'll come back to introduce the speakers for this great occasion. I would like to also welcome our online viewers. Please don't leave your set because we are about to taste an excellent knowledge that will impact on what we do day by day to improve patients' quality of life. So shall we please help me invite Mr. George Courier.
Thanks, Jonas, for the kind words. We are from Kenya, and you know, when you say Horn of Africa, as Prof has said, Somali comes into the mind. So from Kenya with my colleague James. First and foremost, I would want to appreciate your presence here. It's not something we take for granted. And I know the viewers who are also online, we also appreciate the fact that you have spared time. I think for me, what I would want to say is to promise you that at the end of this session, once the two speakers are done, there will definitely be something that you are going to learn. But importantly, your patient will be at the center and at the core of each and every discussions that will be made today. So that's a promise I'm making to you. And I want to believe and trust that you will get out of this meeting with something. Yesterday, I had the privilege of visiting, some of you in your clinics, which was humbling and also refreshing, reminding me of my old days when I was in what I call the trenches, because I believe all of us, even Prof, he did his trench work, and that is why he's a professor. So I think that is a gift that God has given all of us. We must do our trench work before we also sit on the other table, on the other chairs. So one of the questions I was asked yesterday, why are you launching Synjardy? This product has been here for some time, and we know it. And I think the person who asked me, I can see him here. And I told them, Synjardy and the Ghana healthcare providers is like a marriage that has never been formalized. And today we are here to witness the formalization of this marriage so that each and every person can now, if they see Synjardy with another man or another woman, they say, my friend, you are taken. You belong to the other man or the other woman. That's the reason why we are here, to formally launch the product. And I know it is something that some of you have already used and you have seen the benefit of this product. I think the other thing I would also want to highlight is, just briefly, is that I'm sure you have noticed that Boehringer Ingelheim, as you look at the logo there, you see we have Boehringer Ingelheim and DP World. And at times somebody would ask, why do we have the two? And it's important I briefly explain why we have the two. As from 2024, the organization saw it fit to change what we call our target operating model within Sub-Sahara. That is Kenya, all the way going to South Africa, including Namibia, Mauritius, Ghana, and the entire Sub-Saharan countries. So we have our partner, who is a DP World. DP World is a logistics company who aggregates not just for us, but for many multinational pharmaceutical companies, and they bring some core competencies that we as an organization were lacking within Sub-Sahara. And they host what we call our customer-facing team, who operate under them, however, under the brand of Boehringer Ingelheim as the organization that is dictating and directing each and every conversations they have with you. So that's the reason why you see Boehringer DP World. So it is still Boehringer Ingelheim, but DP World is the one that is executing on our behalf. However, Boehringer Ingelheim is in charge of each and every conversation and each and every discussion that happens between them and you. So I think it's important I highlight that. Boehringer Ingelheim is still in the Ghanaian market. Actually, if I was to say, we are, you know, when you sit with, let me say, one buttock and the other one, it's like you're standing. We are firmly seated in Ghana, and we are not in a hurry to leave Ghana. And we are still here to work with you to make sure that we meet your needs as far as, you know, areas of convergence where we are. So for those few words, I would want to welcome again Jonas so that he can take us on the next steps. And I trust that at the end of the day, each one of us is going to learn something for the benefit of our patients. Thank you.
Thank you very much, George. Before I briefly introduce the speakers and invite the first speaker, I want us to acknowledge the presence of Mr. Yao Ejaku, who is part of the senior leadership team of DP World. I can assure you that without this man, you will not get any of these products from you know, your distributors to prescribe for your patients, because he ensures that the products come into this country, not just in volumes, but it's also mindful of the quality of product that comes into the country. Mr. Jaco, we really appreciate your presence here. Thank you very much. Oh, please, if you want to clap for him, please do so. Thank you very much. Well, for this all-important product launch, we have two key speakers. And this afternoon, as I was reflecting on the choice of these speakers, I have known Professor Ernest York many years ago. Many years ago, when I started repping. Mr. Yao Ejaku are some of our mentors, because they have been on the field before. In fact, they actually motivated some of us to, you know, start or go into medical repping. And when we started, we met the likes of Professor Ernest York at the Department of Medicine. So that should tell you that he's not a small boy. And then we saw the likes of Dr. Nikwe, you know, medical school. And they used to come to the medical block for their Friday morning meetings. And when you move into that meeting, it's like you are in the high court, because you see all the gurus in front. And when we are presenting, at times I pity the residents at the time, because they can make their life very, you know, sorrowful. But I have seen this man making a lot of impact. Our first speaker is Dr. Nikwe, who is a consultant endocrinologist and is a son, not a father, he's a son to Professor Ernest York. So here in this product launch, we have father and son issue. So it means that we are going to cover from archaeology to zoology. You understand what I'm talking about? So it means that it's knowledge packed. It's not just about Synjardy, but something that will really shape your practice. Like I said, Dr. Nikwe is a consultant endocrinologist at the Department of Medicine. He will be our first speaker to deliver the lecture. And then after that, we are going to invite our keynote speaker, if I'm allowed to use that word, the man to officially expose us to Synjardy and then launch the product for us. Is the person of Professor Ernest York, and as you know him, is a consultant endocrinologist, diabetologist as well, if I'm allowed to use that. He's also currently the chairman of GMA, Ghana Medical Association. So after the launch, please, if you have an issue, probably not today, tomorrow you can see him at the Department of Medicine, and then you can discuss your issue with him. On this note, permit me to welcome to the podium Dr. Nikwe.
Hello. Hello. Okay. I can be loudly heard. So thank you for the opportunity. I'm here with my father, Professor Ernest York, and he's not just the chairman, he's the president of GMA. He's also the president of DEMSOC, and soon to be other presidents. So, so you're all welcome to the program. I'll take you for the next few minutes. So my topic for this evening is managing diabetes, guideline-based and Ghanaian perspective. So we'll go through the current guidelines in terms of diabetes management, and then we'll see what the new things are about in terms of diabetes management. I'm not sure whether... Sorry, it was off. So this will be a disclaimer for the presentation. The material within the presentation is by me and not from BI, so they cannot be held liable for the content of this presentation. This will be the outline. We'll talk about a clinical vignette, and this will be very, very instructive in terms of the current trends in management of type 2 diabetes. And then we'll talk about the in-thing CKM concept in terms of management of diabetes, then current targets for blood pressure and LDL, and then the 4 pillars to prevent diabetes complications by the ADA. Now we are all having 4 pillars. So at the end of the presentation, I'll ask whether you have any 4 pillars in your subspecialty. So this is the clinical vignette. Mr. Thomas Mensah, he's a 60-year-old male diagnosed with infarctive stroke a year ago. He's referred to your clinic. Now he has a history of type 2 diabetes and hypertension for the past 10 years. And he's been obese for the past 20 years. Following the stroke, he has no neurological deficits, and he mobilizes very well. Currently, he's on metformin 1 gram BD, candistatin 8 milligram daily, he's on clopidogrel 75, and atorvastatin 40 milligram daily. Now, on examining Mr. Thomas Mensah, his BMI is 38 kilogram per meter squared. That's class 2 obesity, so he's quite obese. And his blood pressure is 148/90. He has fatty liver on ultrasound scan. His urine ACI is 350 milligram per gram, and it's been more than 300 in the last 6 months on 2 occasions. His current eGFR is 87, HbA1c of 8.7%, LDL of 1.9 millimole per liter. And this is the LDL trend over the last 4 years, 3.7 to 1.9. So my questions, what further treatments would you consider based on the current ADA guidelines for Mr. Thomas Mensah? What is your target blood pressure and LDL goal for him? And what treatments will you consider based on his fatty liver disease? And with that, as we do usually, you'd want to go through the patient's history and to list problems that he has. So if you take the infarctive CV that he has, that is an established atherosclerotic cardiovascular disease. Now, he is 60 years. The current ADA guidelines say that if you are 55 years and you have 2 additional risk factors, you are at a very high risk for cardiovascular events. So he has 4 different events out of the possible 5. He has hypertension, obesity, dyslipidemia, albuminuria. He doesn't smoke. And so he's at a really high risk of getting a CVD event. However, he's already gotten one. One event begets another. So this is a patient who is like a potential bomb. He can explode another day with another MI or with a stroke. And his urine ACI is 50 milligram per gram. If you look at his eGFR of 87, you will say, oh, his kidney function is not too bad. But persistently, he has macroalbuminuria, and this is a risk factor for cardiovascular disease. He also has fatty liver disease, and he has hypertension, obesity, dyslipidemia. He has metabolic syndrome, a high risk for CVD events. So Mr. Thomas Mensah's profile is a very high risk for CVD. Now, what do the guidelines say in terms of management of such patients? So the 2026 ADA guidelines say that anytime you have somebody with type 2 diabetes, lifestyle management remains the bedrock, the backbone in terms of management of these patients. But look for cardiovascular and kidney risk reduction beyond lifestyle, and look for the presence of an atherosclerotic cardiovascular disease or indicators of a high risk for CVD. If the person has, then choose between a GLP-1 receptor agonist or an SGLT2 inhibitor in terms of management of the patient. Now, the order of the wording is really important. They write this first before this, and we'll go into it in the subsequent presentation. So the next thing you have to look for is heart failure. If the person has heart failure, this time they say clearly that use an SGLT2 inhibitor preferentially first for patients with either current symptoms or prior symptoms of heart failure. And for this category, either the patient has heart failure with a reduced ejection fraction or with a preserved ejection fraction, SGLT2 inhibitors are supposed to be used first line. Now, for the GLP-1 receptor agonists, they are second line in terms of management of our patients. In this category, we should use them for patients who are currently symptomatic, who are obese, and the restriction is patients with heart failure with preserved ejection fraction. The third category that they say we should look at is CKD, in the presence of CKD. If the person has CKD, then our SGLT2 inhibitors remains first line, and then the GLP-1 second line. But a caveat, you can combine these 2 medications. So it's not that one medication is fighting against the other. These 2 medications can be combined. And you realize that at the algorithm, beginning of the algorithm, these 2 classes of medications, they've changed the guidelines in terms of management of type 2 diabetes. Beyond these 3 important parameters, the next important thing to look at is metabolic goal. So glycemic goal and then weight goal. And we can select between very high efficacy, and intermediate efficacy medications for our patients. Let's look at the evidence why they decided that we should use this and that in terms of management of these 3 categories of patients. I forgot to mention, in small print, there's a drug here called pioglitazone. So pioglitazone was with us many years ago. They really write it in small prints, but I made it big print on my version. So that's where it's placed. So it can also be used if the patient has ASCVD or CVD. But the evidence for this is relatively weak compared to GLP-1 and SGLT2 inhibitors for ASCVD events. Now, for Mr. Thomas Mensah, what is the current evidence showing that he is to benefit from this drug or that drug when it comes to cardiovascular outcome trials? We'll talk about 3 major outcome trials, and we are starting with the cardiovascular outcome trials. So for GLP-1 receptor agonists, we'll talk about the LEADER trial, SUSTAIN-6, and the RE1 trials. So they recruited patients with type 2 diabetes, patients with cardiovascular disease, and they followed these patients up for a median of 3 years. Let's look at a few important things about these patients. They wanted to find out whether the use of a GLP-1 receptor agonist would reduce the incidence of 3-point MACE among these patients. We all know 3-point MACE is cardiovascular death, non-fatal MI, and non-fatal stroke. So these 3 drugs, using liraglutide, semaglutide, and dulaglutide, will they reduce 3-point MACE for patients offered this class of medication? Now, if you look at the evidence, all 3 trials reduce 3-point MACE, importantly. Now, the most significant relative risk reduction was by semaglutide, reducing it by 26%, whereas the other 2, 12 and 13%. But of note, the benefits started at about 1 year and over. So if you put your patient on a GLP-1 receptor agonist, hoping to reduce the risk of the composite of these 3-point MACE elements, You will not get the benefits at 3 months, at 6 months. From 1 year on, that's where the curves began to separate. So if a patient has to be on the drug for like 2 weeks, they can't afford a GLP-1. The GLP-1s are quite expensive. For 3 months, for 6 months, they will not derive the benefits in terms of 3-point MACE reduction. But beyond 1 year, the benefits would accrue. So find out whether the patient can afford 1 year and beyond, and then you can initiate this class of medication. Now, if you take the individual components of the 3-point MACE, non-fatal stroke, 2 of the trials showed benefits. So you can see almost about 28% relative risk reduction when it came to non-fatal stroke reduction. The leader trial, however, didn't show any significant non-fatal stroke. But these were secondary outcomes. The primary outcome was the 3-point MACE, for which all 3 showed benefits. If you take myocardial infarction, heart attack, all 3 did not show any significant difference between placebo versus the active agent that was used. And if you take cardiovascular death, only one of them showed a benefit in terms of reduction of cardiovascular death. So if you look at the summary of these 3 findings, 3-point MACE reduction, which was the primary outcome, all of them showed benefits. These were secondary outcomes, and 2 of them showed stroke incidence reduction, and then 1 of them showed cardiovascular death and death from any cause reduction. With these, the guidelines changed, and the guidelines now say that we can introduce a GLP-1 receptor agonist to reduce 3-point MACE in patients who are at high risk for cardiovascular events. And if you look at the GLP-1 receptor agonist, I've mentioned the first 3 trials, but there are other trials like the Amplitude O and the Harmony trials that have also showed benefits in terms of 3-point MACE reduction. So all 5 trials have 3-point MACE reduction. And if you compare it with the SH2 inhibitors, which is our focus for today, using empagliflozin, our prototype medication, EMPA-REG trial is a very standalone and standout trial. We'll talk about this briefly. But the evidence for cardiovascular outcome trials goes more for GLP-1 receptor agonists. And that's how come in the algorithm, they write this first and then they write this one second. We'll look at this in a bit. So for the SH2 inhibitors, EMPA-REG was the first trial that was published in 2015. That showed that for the first time, beyond glucose control, we have a drug that controls and reduces the incidence of cardiovascular events, protects the kidney, and reduces heart failure hospitalization. So look at the EMPA-REG trial. For the first time, there was a 14% reduction in terms of 3-point MACE, a 38% reduction in terms of cardiovascular death. And for the composite of cardiovascular death and hospitalization for heart failure, there was a 34% reduction. Whereas for hospitalization for heart failure, 35% reduction. These were new findings beyond glucose control, that a drug made for diabetes control was now showing benefits across these. And if you look at the hospitalization for heart failure, all 4 of the trials showed benefits. When it comes to 3-point MACE reduction, in terms of SH2 inhibitors, not all of them showed 3-point MACE reduction. The EMPA-REG did show, Canvas did show, but the rest didn't show 3-point MACE reduction. And hence, they write the GLP-1 as the number 1 when it comes to 3-point MACE reduction for CVOT trials. What about renal outcome trials? Kidney-specific trials? Which drug will you choose for Mr. Thomas Mensah? Would it be a GLP-1 or an SH2 inhibitor when it comes to protecting the kidneys? And with that, I'll start with the GLP-1 again. So we'll start with the FLOW trial. And for the FLOW trial, they recruited patients with type 2 diabetes and CKD, patients with eGFR cutoff of 25 or higher. They followed these patients up for a period of 3.4 years. Importantly, the trial was stopped early on account of clear benefits of semaglutide use versus placebo. And this is a very important trial that we must know about. Semaglutide can help reduce renal events. The primary outcome for the FLOW trial was the onset of kidney failure, at least 50% reduction in eGFR from baseline, and then death from kidney-related or cardiovascular causes. This was reduced by 24%. And here again, you realize that the benefit started from about 12 months, 1 year on. So in terms of CVOT trials, in terms of renal outcomes, the patient who is on a GLP-1 must be on this drug for about a year. And similar for SH2 inhibitors, you must put the patients for about a year before you see benefits. And if the patient can afford, we must let them know about the nuances in terms of that. Now, the FLOW trial showed that there's reduction in urine HCl, and importantly, if you offer them semaglutide, it slows down the rate at which the kidney function declines. You realize that the patients offered placebo had a steeper decline compared to patients offered semaglutide for this trial. Now, secondary outcomes from the earlier trials I mentioned RE1 trial, the SUSTAIN-6 trial, all showed reduction in terms of urine ACR and then slowing down in terms of the kidney function. And these put together changed the guidelines. So the guidelines now recommend that we can use a GLP-1 in terms of protecting the kidney, reducing the progression of CKD. We can use dulaglutide, liraglutide, and semaglutide. But for the evidence, if you look at the real evidence, you'll realize that the FLOW trial is the only renal-specific trial for GLP-1 receptor agonists. Whereas when it comes to SGLT2 inhibitors, we have major trials in this space. So when it comes to the kidney, this is number one. When it comes to CVO2 trials, this is number one. But as I mentioned, you can combine them. So it's not like Haas versus Kotoko or Ghana versus Nigeria in terms of football. They can be combined for benefits. Now, look at the Credence trial published in 2019 all the way to empagliflozin in 2022. These trials showed evidence in terms of renal protection. The horse had bolted, and then in 2024, the GLP-1 then showed that they also have some benefit when it comes to the kidney. But the evidence for SGLT2 is really there. Let's look at this evidence. So the Credence trial recruited patients with CKD and type 2 diabetes. They only recruited patients with type 2 diabetes. This trial recruited patients with 67% having type 2 diabetes. EMPA kidney trial was the first trial that recruited patients who had more non-diabetic population than diabetic population. 54% of the study participants in this trial didn't have diabetes. And they were still able to show that in the non-diabetic population, this class of medication helps to reduce the rate at which the kidney function declines. So we realize that canagliflozin, dapagliflozin, empagliflozin slow down the rate at which the kidney function declined compared to placebo for the three trials. Look at the eGFR cutoffs for the three trials. Empagliflozin was a trial that recruited patients with the least eGFR and still was able to show that at this low eGFR of 20, if you offer a patient an SGLT2 inhibitor, you would reduce kidney-related events. So this was a major finding in terms of empagliflozin, our prototype medication for today. All three trials were stopped early on account of clear benefit of the agent use versus placebo. Now, these three trials had slightly different primary outcomes, but the theme of the primary outcome was this: will the use of an SGLT2 inhibitor reduce or slow down the decline in kidney function? Would it reduce death from renal or cardiovascular causes? And that was shown beautifully by the hazard ratios of all three trials. The relative reduction was around 30% reduction for all three trials. And as I mentioned, the trials were stopped early on account of clear benefits of the agent's use compared to placebo. Now, if we take the secondary outcome from the CVO2 trials that I mentioned, EMPA, Canvas, and DECLARE, the earlier CVO2 trials that I mentioned, you realize that there was on average about 40% relative reduction when it came to kidney outcomes. And then if you take to the kidney-specific trials, the Credence, DAPA-CKD, and EMPA kidney, there was also on average around 30% reduction in terms of relative risk when it came to kidney protection. Now, you have a myriad of benefits, myriad of evidence in this SGLT2 space protecting the kidney. And this class of medication should be used first when it comes to kidney protection by the guidelines. From 1981, we only had one class of medication that was protecting the kidneys, ACE inhibitors or ARBs. Until the last, let's say, 10, 15 years, this was the only drug that we're using to protect the kidneys. Now, the guidelines recommend 4 different drugs that we can use to protect the kidney. Beyond ACE inhibitors, SGLT2 inhibitors first. As I've mentioned, the evidence goes more for this in terms of the renal space. And then you can also consider GLP-1 receptor agonists. And then you can consider finerenone. These are non-steroidal mineralocorticoid antagonists. The Fidelio trial showed benefits in terms of the use of this. The Figaro trial also used benefits, but the Figaro wasn't a renal-specific trial. It was the Fidelio that showed benefit in terms of the use of finerenone. And my last trial that I want to talk about is the heart failure trials. So when it comes to heart failure, will you use this or an SGLT2 inhibitor in terms of Mr. Thomas Mensah in his presentation? Where does the evidence lie? So for this too, I'll start with the STEP-DM trial. So the STEP-DM trial used semaglutide, and they recruited patients with type 2 diabetes, patients with heart failure with a preserved ejection fraction, and their cutoff was 45%. They followed these patients up for 52 weeks, and it was obesity-related heart failure in type 2 diabetes. Let's see what the primary endpoints were. The primary endpoint was the change in the Kansas City cardiomyopathy questionnaire, and then the percentage change in body weight. This Kansas City cardiomyopathy questionnaire assesses heart failure-related symptoms, physical function, quality of life, and social function. So, in summary, what they wanted to find out was, if you offer a patient semaglutide, would it improve heart failure symptoms? Would it improve physical function in terms of heart failure? Would it improve quality of life? Versus also, would it also reduce the body weight of these patients? And we know already that this class of medications, they are very good when it comes to body weight. I don't know why they added this as another endpoint in terms of this heart failure trial that they organized. But importantly, what you can see is that the semaglutide arm had an improvement in the Kansas City score. For the Kansas City score, the higher the score you are, the better you are in terms of heart failure. The placebo arm also had an improvement. And the placebo arm didn't receive water. They also received the guideline-directed therapy. And that's how come you are seeing improvement, except that they didn't receive semaglutide. So this arm received semaglutide versus other guideline-directed therapy. And you realize that if you offer a patient semaglutide, there's improvement in terms of heart failure, symptoms, and function. So the weight reduced in terms of the use of this drug. And this one, I think we are all aware of this. So this is not a new finding in terms of the outcome of this trial. In patients who didn't have diabetes, the STEP trial without DM, also the same evidence was shown. So in terms of the guidelines, the ADA guidelines, 2026 guidelines, recommend the use of this class of medications based on these two trials that I've mentioned and the SUMMIT trial. The SUMMIT trial looked at tirzepatide. And we know tirzepatide is a dual GIP/GLP-1 receptor agonist. And so now the evidence goes for these three. And the evidence is that we can use GLP-1 receptor agonists for patients who are obese, patients who have heart failure with preserved ejection fraction, and who have current symptoms of heart failure. So that's a restriction in terms of the caveat for use of this class of medication when it comes to heart failure. So you realize that these trials that I've mentioned, these three trials, they are for a restricted caveat of patients who have heart failure. They are obese, they are currently symptomatic, and they have heart failure with preserved ejection fraction. When it comes to SGLT2 inhibitors, there's no restriction in terms of whether the person has a reduced ejection fraction or preserved ejection fraction. And there's a myriad of medications, a myriad of trials that have been done in the last few years. So from 2019 all the way to 2022, you can see evidence across board. I'll talk about this briefly because this may be important in terms of if you are to be asked by a patient, what's the evidence for the use of these medications? So these first two trials look at patients with reduced ejection fraction. The next three looked at patients with preserved ejection fraction. And the last two looked at patients with acute admission. Now, let's look at the evidence for the use of these medications in these trials. So for heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction, across board, you would realize that all the trials that were conducted, there was on average around 22% relative reduction when it came to this. The primary outcome for all these trials was, with the use of an SGLT2 meter, reduce the composite of hospitalization for heart failure and then cardiovascular death. So these two primary outcomes were reduced across board by all these four trials, and this is the reason why there's no restriction when it comes to the type of heart failure that you can use these medications for. Empagliflozin in the EMPEROR reduced trial, EMPEROR preserved trial, and the EMPEROR preserved trial have showed major benefits across board in terms of the use of this class of medication. Now, when it came to a meta-analysis, the major benefit with respect to reduction in heart failure hospitalization has shown in this meta-analysis for patients with reduced ejection fraction. And then for patients with preserved ejection fraction, similar was shown. The major benefit has to do with reduction in heart failure for hospitalization. And that's the key finding in terms of the meta-analysis. I wanted to highlight on this slide a major thing that the empagliflozin arm of the trials showed. So you realize that for the heart failure specific trials, these four trials, major trials, dapagliflozin, empagliflozin, they recruited patients with eGFR factors of 30, 25. It was the empagliflozin arm that recruited patients with the least eGFR and still showed that at the eGFR of 20, a very low eGFR of 20, you will still have heart failure benefits when you use this class of medication. So for renal space, this class has benefits, and for heart failure space, this class also has benefits. When it comes to, now we use empagliflozin, dapagliflozin on the ward. The main trial that showed benefits on the ward is from empagliflozin in the EMPULSE trial, and then the SOLOIST WHF trial. We don't have sotagliflozin in Ghana, but this trial also recruited patients only with type 2 diabetes. The empagliflozin trial recruited patients with diabetes and non-diabetes, and were able to show that in hospital, when the person is acutely ill, receiving IV diuretics, you can still use this class of medication and you derive a lot of benefit in terms of reducing heart failure hospitalization and improving survival for these patients. And the main trial is the MPOS trial. So in acute setting, it's safe to introduce this class of medications based on this MPOS trial and the Soloist WHF trial. Now, the Soloist WHF trial recruited patients who were just about getting discharged in the next 3 days after discharge. But this class of medications were used in hospital without anybody recruited after discharge, and still showed immense benefits in the acute space in terms of heart failure. So what about metabolic impact of these drugs? So the first thing that the ADA guidelines now recommend is look at these 3 parameters, and then if the patient doesn't meet these parameters, then go ahead and look at these parameters. These will guide you in terms of selection of medications. So now we are on glycemic goal and then weight goal. Let's look at the evidence. Mr. Thomas Mensah's BMI is 38 kilogram per meter squared. He has a class 2 obesity. His HbA1c is 8.7%. This is quite high. How do we reduce the HbA1c of 8.7% without compromising the BMI? Now, if you offer him a softener urea or insulin, it will reduce the HbA1c, but unfortunately, it will increase his weight. So that would not be too beneficial. If you offer him a DP4 inhibitor or metformin, it will be weight neutral, but it will improve his HbA1c. If you offer him any of these 2 classes of medications, which have changed the guidelines immensely, you would have HbA1c reduction and weight reduction. And this would be the preferential medications you want to select from in terms of Mr. Thomas Mensah's management. Now, current evidence shows that if you lose weight, at least 5% body weight, you would reduce hyperglycemia, you will reduce blood pressure, and you reduce dyslipidemia. If you're able to achieve as much as 10% body weight, you may send type 2 diabetes into remission. You will improve fatty liver, you will improve sleep apnea, and then physical comorbidities like arthritis. And the evidence in terms of very high efficacy, intermediate efficacy, and then neutral effects in terms of weight are as highlighted. When it comes to HbA1c reduction, insulin remains the most potent. However, I've also showed the benefits in terms of the new drugs and then the relative reduction in terms of HbA1c. Now, Mr. Thomas Mensah has cardiovascular disease. He's developed a stroke. Cardiovascular disease is a risk factor for hypoglycemia. In selecting a patient for patients with CVD, patients with advanced age, renal impairment, liver impairment, we must select agents that have a low risk for hypoglycemia, including our prototype medication for this evening, and then metformin. These drugs have low risk for hypoglycemia. Hypoglycemia is not a benign condition. It can lead to arrhythmias. It can lead to cardiac arrest. Hypoglycemia can lead to seizures. It can lead to dementia. It can lead to weight gain. And who knows how hypoglycemia can lead to weight gain? Any of us. If you have recurrent hypoglycemia, what you tend to do is that you tend to eat defensively. So the patients who are always getting sugar of 2.1, 1.0, they eat defensively and they gain weight. Once they gain weight, they get more insulin resistance. If they have more insulin resistance, you have to increase their medication dose. And if you increase their medication dose, they'll then get hypoglycemia. And it's a vicious cycle of getting into hypoglycemia. So selecting medications that have a low risk of hypoglycemia among patients who are high risk for CVD or CVD is really important. Now, Mr. Thomas Mensah has fatty liver. What is the current guidelines in terms of protecting his fatty liver or reducing it? It's pioglitazone and then the GLP-1 receptor agonist. So pioglitazone, our old friend, our Laimomo, has come back. Now it has fatty liver benefits and it also has ASCVD benefits. But the ASCVD benefits, the IRIS and the proactive trials, they're not as major as the other GLP-1 and SGLT2 inhibitor benefits in that space. When the patients come to the ward and the person has decompensated cirrhosis, what we should use is insulin. For lipids, these 2 classes of medications have very marginal effects on lipids. SGLT2 inhibitors don't seem to have so much good effects. They increase LDL and they increase total cholesterol, whereas GLP-1 receptor agonists reduce LDL and they reduce total cholesterol. But they both reduce triglyceride, which is good. SGLT2 inhibitors, however, improve HDL, which is good, whereas this reduces HDL. But the effect in terms of lipids is so much that it can be ignored. This class of medications also reduce blood pressure, very importantly. So they both reduce blood pressure, and it's like one drug with many benefits. And this class of medications, the SGLT2 inhibitors, they do this by natriuresis and then by decreasing intravascular volume. They reduce both systolic blood pressure and diastolic blood pressure. Whereas this one, the main benefit is with systolic blood pressure reduction. I've showed the mechanism by which they both achieve blood pressure reduction. Importantly, the GLP-1 receptor agonists also increase heart rates. Unfortunately, when they started, they were fearing that this class of medication may lead to arrhythmias. But from thorough analysis of the evidence, the rate at which they increase the heart rate, the average rate is between 2 to 4 beats per minute. So not a significant increase in the heart rate, but they do increase heart rates. And they thought this could have an arrhythmogenic potential, but it hasn't been shown across board. So the benefit is with BP reduction. So what is your target BP for Mr. Thomas Mensah? His BP currently is 148/90. What is your current BP in terms of the current guidelines? The 2026 ADA guidelines say that his BP should be less than 130/80 if it can be safely attained. And for him, he has cardiovascular disease, he has a stroke, he has a high risk, as I mentioned at the beginning. He also has a high kidney disease, he has macroalbuminuria. His target should be 120. So for him, ideally, he should have a solid blood pressure of less than 120. He's currently doing 148/90. That's a bit high. However, I like this caution that they give because they say if it can be safely attained, it means if you increase your dose of your candesartan from 8 to 16 and he starts getting symptomatic hypotension, you must be cautious. So whereas the target is 120 for most of our patients if they have high cardiovascular risk and kidney disease, 130 is for just diabetes without this increased risk. We must achieve these targets safely. If the person has symptomatic hypertension, we must target around 140/90. If they have orthostatic hypotension, if they are having moderate to severe frailty, these patients can fall because of a reduction in BP. And if they have a limited lifespan, for these patients, relax the BP target. Otherwise, 130/80 is a fair target. And if they have a high cardiovascular kidney risk, 120 is the systolic blood pressure of choice. And we shouldn't be afraid of bringing the BP down. Many years ago, we were afraid of, oh, this person is 60 years. If you bring the BP down, it will get some events. But currently, there's a lot of evidence showing that we can bring the BP as low as systolic blood pressure, low as 120, and still derive benefits. So vascular events were reduced in the BP road trial, which recruited only type 2 diabetes, and showed that at a BP as low as 120 for systolic, you reduce vascular events by about 21%. And same for the ESPRIT trial. This recruited both diabetic and non-diabetic patients. This was only pure diabetic patients. And this is published as recently as 2024 in the New England Journal of Medicine, 2023 in the American Heart Journal of Medicine. So now the ADA guidelines have now also improved in terms of the evidence for which they are recommending a lower target for BP control. Now the SPRINT trial didn't recruit patients with diabetes. So they excluded patients with diabetes and still show that at this BP, if you reduce blood pressure to this target, you reduce vascular events. But importantly, you also reduce all-cause mortality. So there's a lot of benefits if we can attain this safely and safe for the STEP trial. And this recruited patients with diabetes and without diabetes. And that's the evidence in terms of why we should bring our BP down. Now, the first line medication for BP control in terms of patients with hypertension and diabetes, we all know is ACE inhibitors or ARB. What we don't do is that once we start them on this class of medication, we don't titrate to maximally tolerated doses. But all the trials I've mentioned in terms of the CKD evidence, Credence, DAPA-CKD, EMPA-KIDNEY, it was on top of maximally tolerated ACE inhibitors and ARB that we saw the benefit of SJ2 inhibitors. So that should be our target. Now, Mr. Thomas Mensah, who has a urine ACR of 350 milligram per gram, what does the current evidence show in terms of reducing this urine ACR? They say if you can attain 30% reduction in this urine ACR, that is around 105 milligram per gram, you reduce the rate at which his kidney function declines. And so for him, if you are monitoring him, you must look at the absolute value of the urine ACR. If it's able to attain less than 245 milligram per gram in terms of your ACE inhibitor or ARB that you are using, then you are good to go. If it's not, you increase your ACE inhibitor or ARB until you can achieve this, and it must be maximally tolerated dose. Now, if you're able to achieve less than macroalbuminuria levels, less than 30 milligram per gram, the current evidence shows that these two criteria, you will reduce the rate at which his kidney function will decline for Mr. Thomas Mensah. Now, if the patients come and they have BP of 150/90 or higher, you can start 2 drugs ab initio for them, but less than this, 1 drug at a time in terms of BP control. What about his lipids? You realize that in the last 4 years, his LDL has ranged between 3.7 and 1.9. He had a stroke last year, and his LDL was 2.6. His current LDL last month was 1.9. Do you think it's being managed very well, diabetes, with this LDL targets? after suffering a stroke. So the current evidence shows that if you have a stroke and you have any of these features, your target LDL should be 1.4 and below. So MI, stroke, and the rest of these features as shown. But if you have type 2 diabetes for more than 10 years, then your LDL target should be 1.8 or below. So you realize that for Mr. Thomas Mensah, for the last 10 years that he's had type 2 diabetes, he's never been able to attain LDL of 1.8 or below. So the patient's LDL management was not a target. His BP was not a target. His sugar control was not a target. And no wonder he developed a stroke after 19 years of developing obesity. This is the import of today's presentation. We must treat patients, not just offering them medications, but we must treat them to targets. Diabetes of 10 years and more, the target LDL is 1.8 or below. And this brings us to the 4 pillars to reduce diabetes complications in terms of ADA guidelines. So now it's not just sugar. We're not just focusing on glucocentric elements. Blood pressure management is important and to targets. Lipid management important to targets. And the 4th pillar is agents with cardiovascular and kidney benefits. So these are the 4 pillars when it comes to preventing complications in patients with diabetes. So now, Dr. Florence Akumia will not worry me that she has 4 pillars for heart failure management. Now I also have 4 pillars for diabetes management. I hope if you are doing dermatology, you also have some 4 pillars for maybe Stephen Johnson's management, or if you are doing gastro, you have some 4 pillars for management. But on top of these 4 pillars, or beneath the 4 pillars, is lifestyle modification. So let's not just do medications, you must also offer lifestyle. And refer our patients to the dietitian. Lifestyle can bring HbA1c down as much as 2% and 1.9 for type 1 and type 2 diabetes, respectively. Salt reduction is also very important. When we finish cooking and you're about to eat, then you say that, oh, you taste the food and you add some extra salt. This can lead to hypertension and can give you problems. Then alcohol intake for men, we can take 2 drinks. What men can do, women can do. A woman is supposed to take 1 drink, according to ADA 2026 guidelines. Sometimes you would go to a joint and you see two gentlemen with about 12 bottles. They are far exceeding the bottles. You can only take 2 drinks per day. And I've tried to break the drinks down. If it's spirits, 44 mils is 1 unit. So you can't drink more than 2 shots, 88 minutes per day. Those who take more than 2 shots per day, they're exceeding the units per day. And if it's beer, 355 mils. So mini beer 2, and that's it. But you see 2 gentlemen with either this or with this, and they are really having a good time. Now, exercise therapy is important, but before you prescribe exercise therapy, make sure that they don't have proliferative diabetic retinopathy or severe non-proliferative retinopathy. Assess for loss of protective sensation in the feet. If they have Charcot joint, if they have severe cardiorespiratory dysfunction, you must know how you prescribe exercises in terms of these patients. Now, we all know about moderate intensity exercise, vigorous intensity exercise, and what I want to stress is resistance exercise. Sometimes we preach this, but we don't preach this. This helps to maintain muscle mass. So let's encourage that they do both. And if you do exercise, it can reduce your BP down by about 8 millimeters of mercury. Now, Mr. Thomas Mensah is a prototype patient that we see every day. And if you don't remember anything at all, let's remember this slide. I think this is my take-home slide, though I've not finished yet. So at the age of 40 years, he developed obesity. 10 years later, he developed diabetes and hypertension. He had moved from stage 1 CRM to stage 2. If his therapy was carefully selected and the agents that will reduce stage 4 development were selected at this age when he was 50, by 59, he wouldn't have developed stroke. Now, 1 year shy of retirement, he has a stroke. All his retirement is small money he's going to spend on medications. This is the import of today's presentation. When we catch patients at stage 1 or stage 2, let's select medications that will reduce the progression along this stage. So this is the American Heart Association staging for CRM or CKM as it's called now. Now, if you select appropriate medications, will prevent people like Mr. Thomas Mensah from going to stroke. As we are aware, stroke is the commonest killer in Ghana. Ghana has the highest burden when it comes to the global burden of disease. In 2021, the global burden of disease for stroke, we had 2,046 cases per 100,000 population. The whole world, we had the highest number. The stroke that we are seeing on the wards, they are killing a lot of people. what we can do to reduce this incidence is to manage diabetes, hypertension, obesity. The 4 pillars that I mentioned in terms of the ADA guidelines when it comes to reducing diabetes complications, there are major things that we must focus on in terms of reducing the risk. If you have diabetes, you have a 2 times risk of getting a heart attack. You have a 2 times risk of getting an ischemic stroke. Diabetes is a benign disease, and we must manage these patients well and select agents that will reduce this risk appropriately and timelessly before they come down with these complications. These 2 classes of medications have changed the guidelines. Now they can break the cycle of getting to stage 4. And if Mr. Thomas Mensah had received these medications earlier on at stage 1 or stage 2, he may not have succumbed to stroke at the age of 59. When it comes to heart failure is not a benign condition. Now, 50% of patients with heart failure die by 5 years. We should catch them when they have stage A. Only risk factors like Mr. Thomas Mensah. Now he has hypertension, diabetes, dyslipidemia. And then if he has LVH, he has stage B. We shouldn't allow them to go to stage C when they have symptoms of heart failure before we offer them guideline-directed medical therapy so that we reduce the incidence of heart failure. Because once they get heart failure, by 5 years, 50% of them will not be around. However, if you catch them at the time they already have heart failure, there's a plethora of evidence from 4 major landmark trials that shows that if you offer them these medications, you will still reduce the incidence of hospitalization for heart failure and the composite of cardiovascular death and hospitalization for heart failure among these patients. Now, ACE inhibitors have been around since 1981, as I mentioned. We shouldn't use them alone. There's current evidence that if you combine them with SGLT2 inhibitors, you slow down the rate at which the kidney function declines. And so you protect the kidney from getting to end-stage kidney early. And this is a very important quote, but I'll leave this because of time. And if after my presentation you want me to explain the reason why now 2 classes of medication are doing miracles. They have about 8 benefits for just 2 classes of medications. It's like, if you're on a trotro, somebody says, this medication, it can be used for cocoa, it can be used for this. Now 1 class of medication can be used for many medications, for many indications. Look at empagliflozin, our prototype medication for today. Beyond blood glucose control, empagliflozin can reduce blood pressure, body weight. It can offer cardioprotection. It can offer renal protection. It can offer low risk of hypoglycemia and 3-point MACE reduction from the EMPA-REG trial. Beyond this, it also reduces hyperuricemia. So it benefits with evidence, clear evidence from guideline-directed therapies that we can use this class of medication. And we must offer these therapies appropriately and timeously, not when the patients have developed the events already. And so, as I mentioned, at the end of the presentation, if you want, I'll show the reason why. But in summary, the guidelines have changed, and now lifestyle remains the backbone for management of type 2 diabetes. Beyond lifestyle, look for cardiovascular and kidney risk reduction. And if the person has any of these parameters, the GLP-1 or SGLT2 inhibitors are medications we should think about. If for heart failure or CKD, SGLT2 inhibitors have evidence, and I'll show the evidence in terms of first-line use of these medications. For cardiovascular outcome trials, the GLP-1 receptor agonist. Pioglitazone, small benefits, they write it in small print. I have enlarged this. And then you look at the glycemic goal and then the weight goal in terms of the management. Now, ESC guidelines have changed over the years. The ESC guidelines now recommend the use of this class of medications for patients with heart failure with reduced ejection fraction and heart failure with reduced ejection fraction. Empagliflozin, dapagliflozin. Empagliflozin is our prototype medication for today, as evidence in terms of the use of this class of medications. The 4 pillars that I was referring to by the cardiologists. Now we have some 4 pillars, so we can say we have something small to use. When it comes to the KDIGO guidelines, they've also changed. KDIGO guidelines now recommend the use of this class of medication for patients with CKD from diabetes and without diabetes. As I mentioned, from the Credence, DAPA-CKD, and then the EMPA kidney trials. A very important take-home message. If you see a patient with eGFR less than 60, persistently beyond 3 months, they've developed CKD. If you see them with urine ACR more than 30 milligram per gram, persistently beyond 3 months, develop CKD. With these 2, the guidelines say that you must offer them guideline-directed medical therapies. ACE inhibitors are there, SGLT2 inhibitors are there to protect the kidney from going down. You may see a patient with eGFR of 60 today. In 8 years' time, he has end-stage renal disease. Let's offer them guideline-directed therapy like empagliflozin, SGLT2 inhibitors to slow down the rate at which the kidney function declines and to reduce albuminuria. Now, when it comes to heart failure, that's about a week ago, we had somebody with bilateral PE, confined on CTPA. The person was obese, and he also had BP of 200, 130. It came with biobasal capitation. So we're thinking that, This man has P, evidenced by what we did, the CTPA. But could you also have heart failure? The current definition, the universal heart failure definition, says that beyond the clinical symptoms that we usually use, we must corroborate this with natriuretic erythropeptides and the evidence of pulmonary or systemic congestion. These are all important things. So for our patients, we had to do BNP to be sure that was heart failure, or predominantly P, that was the reason for his dyspnea for the first 5 days of admission. Now, my take-home message in terms of the Ghanaian perspective. I've talked largely in terms of current evidence when the patient has ASCVD or high risk for ASCVD, has heart failure, CKD, obesity, in which the SGLT2 inhibitors or the GLP-1 receptor agonists will be first line in terms of use for patients with type 2 diabetes. However, these medications have shown benefit when it comes to kidney protection and CVO2 protection after about a year. If your patient cannot afford after about a year, they can only afford 3 months, they will not get much benefits. When it comes to heart failure, however, for heart failure, you can see benefits as early as 20 days, 18 days. So for heart failure, these two medications show benefits early. But for CKD and for CVO2, like stroke reduction, that one, you need to be on a medication for about a year or so to reduce it. So let's inform them about the need to continue. And if they can't continue, we can offer these medications. Our first line medication for management of type 2 diabetes, in the absence of these, remains metformin. And Prof. York, who championed the 2023 guidelines for diabetes, is also championed the dissemination in the last 8 months. I think last week we had a 5th dissemination. He did the first 2 last year in terms of disseminating the guidelines. Metformin is our first line when it comes to diabetes management in Ghana. So at an eGFR of 30, we have to unfortunately withhold metformin. The current guidelines don't say that we should use it when the eGFR goes below 30. You can start empagliflozin at 20 or higher, and once you start, you can continue until the eGFR drops to 1. We have a nice combination that Prof. York, the GMA president, and the president of DEMSOC will tell us about in the next few minutes. So I won't go into this, but you can combine SGLT2 inhibitors with all other medications. GLP-1 cannot be combined with DP4 inhibitors. Metformin has been around for over 65 years. It's a very solid machine that we have. These new drugs are new friends to develop. Sometimes you get some new lady friends, but you can't leave your old Live-Momo. So our old Live-Momo metformin is still there. On that note, I'd want to say that EMPA-REG trials show the benefit of SGLT2 inhibitors when it comes to beyond glucose control, cardiovascular benefits, reducing 3-point MACE, reducing hospitalization for heart failure, reducing the component of hospitalization for heart failure and cardiovascular death, and has showed that at an eGFR of 20, there's still renal benefits and heart failure benefits. There's long-term safety with empagliflozin, efficacy and durability. It can be well tolerated. You can combine it with other medications. On that note, show me your 4 pillars, and I end on this note. Thank you very much.
Thank you very much, Dr. Nikwe. I initially used Professor York as chairperson. He's not. So I'm sure that's the more reason why Dr. Nikwe keep pushing president. Indeed, he's the president for GMA as well, the current, not the past, current. And probably the president of Ghana to be, maybe in the next 15 years. Anyway, so our key speaker for tonight is no other person than Professor Ernest York. Shall we please welcome him?
Thank you, Jonas. The next 50 years, I'll be over 100. With the president saying it there, it has to happen before 60 years. Because I need to go to Bahamas. So thank you for inviting me. And Dr. Nikwe, let me assure you that the dermatologists have their 4 pillars. They have their steroids, they have their keratolytics, their antifungals, and emollient. And no, I'm kidding. I'm just, somebody said dermatology is easy because of these drugs, but hey, they will argue with you. But let's come back to why we're here today. So Dr. Nikwe has done, my work for me. What I'm trying to do now is to make Jonas happy, because we are here because of Synjardy, which is a combination medication of some of the medications that Dr. Nipet spoke about, that is metformin and empagliflozin. So these are my disclosures, that I was being contracted by BI, being ferried by DP World. And I have no financial interest in these two companies. So I have an independent mind of my own, and that's why I'm here. So this will be my outline introducing the subject of unmet needs in diabetes. We'll look at briefly the mode of action of SGLT2, which Dr. Nikwe has amply spoken about, and I'll probably will be skipping that. Then baguanide mode of action, that's metformin. Then the pharmacology of Synjardy, the clinical data, and tolerance issues, and then we'll look at some of the recommendations that we ought to be aware. They will vary slightly with the standalone SGLT2 because of the combination and why we're using it for our patients. This is a slide that many of you have seen many times, but we keep showing because the predictions that we made about diabetes in terms of prediction, the numbers, we keep surpassing them year in, day out. So every ADA guideline or IDF projection that comes in terms of the world burden of diabetes, they always change. And it's largely due to the presence of undiagnosed diabetes and diabesity. So you can see clearly, okay, so the pointer doesn't work. You can see clearly, let me go back, from the data from Africa, that will be around 142 projected increment from the current numbers by 20. If we are, competing interest in terms of finding money for roads, the schools, the education, and now we have so adverse outcome at one point in their lives, and then the kidney failures So that is where we need to find that balance, because it's been demonstrated in several studies, especially the Accord, that was terminated because of the problems associated with hypoglycemia, that if you push, especially the elderly ones and patients with a lot of comorbidities, they tend to succumb. So where do we find that, fine balance? And that is why we should select molecules that are quite gentle on causing hypoglycemia for our patients. Okay, so Dr. Anikwe spoke about these things. He had even a broader area of complications that he stated. But again, to reiterate the point that it can affect the brain both acutely and long-term, and also even cause dementia, as he stated, cardiovascular event. Arrhythmias, they die suddenly sometimes, and it happens. Poorly controlled sugars, and sometimes, they are put on insulin, they are not monitored well, they get hypos at night, and they die. Nobody knows why. Sudden death, we don't know the cause, and it happens. So we should try and get that fine balance clearly and very well for our patients. Then the effect on hypoglycemic awareness. Anybody who suffers hypo repeatedly for a long time, their body is not able to adjust. Okay, so over time, when it happens, they don't perceive it, and the sugars are one and they are still walking and chatting, they can fall dead immediately if care is not taken, and they reduce quality of life. Dr. Nikwe was speaking about some people who, because of hypo, can paradoxically put on weight. It's a fear of the unknown. So if it happens to you, especially at night, I tell you, patients are really reluctant to increase doses. And I've had patients like that. This old woman, that her luck was that she sleeps with his daughter. And then she was sweating, fidgeting in bed, and the doctor said, let me check your sugar. And it was just 1.2. And then they had to quickly rush her to the hospital. That was when she was saved. And she has sworn that insulin will be. But then she needed it somehow because the other groups are not doing the trick. So if she was able to afford some of these issues, I'm not sure she would have had a medication. I'm not sure she would have had those problems. Okay, so the severe hypoglycemic acidosis, this is emphasizing, what I've just spoken about. Occurs more frequently in elderly patients because they also tend to have a lot of, neurological impairment, and you need that to be intact for you to be able to elicit the appropriate response to hypoglycemia, so that the body mobilizes stored glycogen and glucose stores to be able to boost your insulin glucose levels to prevent that. And these are people who are also have renal impairment, liver impairment. They are multi-drugs that may impact on the sugar level and cause hypoglycemia. So elderly patients with a lot of comorbidity, we need to be careful about the drug selection. And these we know already. I think Dr. Nikwe showed them. Agents with high risk of hypoglycemia, insulin use, and then the glanites, which act similarly like SU, but less notorious for hypoglycemia. And these ones have lower risk, the traditional ones, plus the newer ones like SGLT2 and our old metformin. It's been around since 1960. The Americans, were reluctant about it, but in Europe, they started using it, because of a few incidents of lactic acidosis, not even with metformin, but it was with fenformin. It was withdrawn and they said we won't use it. But hey, Europe, used it and had the benefit that it was associated with it until recently when America were bold to incorporate into their guidelines. And when Europe was using it below 60, America still said we'll use it above 60. And now we know that you can still go below 60, at least around 45, reduce doses, and the patient will be fine. Okay, so these are, again, emphasizing the points that we're making. Insulin, high risk of hypoglycemia, and then glibenclamide follow in that line. I have stopped using glibenclamide, though. Please, I have stopped. It's notorious. It's long-acting. The elderly people, they suffer hypos. I know it's cheap, but please, there are still generic glamepiride that you can use, or other sulfonylureas if you have to use them. And when they get hypos, it takes a long time for them to recover. Mejai, Timusu Munjai, Mamunkanchu, Ouch. What has happened? Period of the complications, safety tolerance issues far. Just it's not that they come by. Well, it is true because many of us here, I'm not sure we have completed yeah, no call a akonedi no call akoswesa yampa. All right. It's a big deal. As much as 50% in the US data, so non-adherence is associated with high risk of hypoglycemia, high rates of medical costs. Measures to improve adherence had an impact on the therapies have a far greater impact on the health of the population than any improvement in specific. How to improve tolerance to improve, compliance. And then environment, somebody is the cause of my diabetes. Beyond that, why me? You know, one or two at a time. So, Jonas, Drew. Okay. So this is telling you with evidence that if she's clearly, it gets worse at the number of pills increased per day. So this is the evidence. All right, insulin, that we tend to that the effects in terms of side effect be additive. You will still retain the favorable components of because of the evidence. Many guidelines also, emphasize that point that combination therapy is a way to go for most controllers. So it is almost 1-to-1. This is what I have to tell you to remind you about the growing burden of the disease in largest increases and problems associated with the disease. And then there's significant impact with gain, especially the insulin and secretagogues, and adherence to therapy regimes and measures that to improve adherence and the taking of the medic. I did was an introduction. Level of the convoluted tubule. Through two receptors, majorly SGLT2 and receptors that is responsible about 90% and very high capacity. Then SGLT2 one is just about 10. So this is where we are. So you achieve the maximum impact, and almost zero glucose is filtered out unless you have exceeded the renal threshold of about 11. Now, the blockage comes by using SGLT2 inhibitors. So the 90%, as you saw, will be blocked, and therefore there's seepage of urine through the tubules, and then you have glycosuria, and that is the reason why the blood levels of glucose go down. So it is insulin independent, okay, unlike you have with the other molecules that somehow directly or indirectly they impact on insulin and insulin resistance. So you have all these molecules here, insulin directly doing that DPP-4s through GLP-1 and then causing further insulin secretion, SGL, SUs, and GLANites. You know them already. And the metformin, impact on insulin resistance with TZDs as well. So this molecule is insulin exclusive. Right, metformin. This is the class 1 version of how it works. At the university level, how it works, the board will be full of molecules, and I'm not sure that is why we are here. We want to have bedside view of how it works so that it probably will stay with us. So metformin has effect at the intestinal level, but majorly it reduces hepatic glucose output and reduces gluconeogenesis and glycogenolysis. And then at the peripheries, we spoke about the impact in reducing insulin resistance. And then it has some effect on lipid metabolism that is quite beneficial. So to make the story simple, what we are saying is that Synjardy is a combination of metformin and empagliflozin, combines two anti-glycemic medicinal products with different mechanisms of action to improve glycemic control in patients with type 2 diabetes. So we know what they are. I won't bore you with that one. So they work together to lower glucose levels in different ways. However, neither stimulates insulin secretion and are therefore associated with lower risk of hypoglycemia, because hypoglycemia can be devastating. So let's look at some pharmacology of the two products. So this is the indication for Synjardy. Adults 18 years and above with type 2 diabetes as an adjunct to diet and exercise. Dr. Nikwe says so. So lifestyle changes is still the backbone. It hasn't changed and it will never change to improve glycemic control in patients. Inadequately controlled on either maximally tolerated dose of metformin alone and also inadequately controlled with metformin and in combination with other glucose-lowering medications. So it can be used alone or in combination, and already been treated with a combination of EMPA and metformin as separate medication. Now you want to put them together for simplicity and also for cost issues. But there's a but. It is not indicated for EGFR less than 60. Okay, because of the dual, the molecules, right? It is not for, so we're looking at largely glycemic control. Okay, so if it's just for glycemic control, you're looking at EGFR 60 or above. But occasionally, under specialist supervision or cautiously, you can use it up to about 45. Then it can also not be used in patients with hepatic impairment, elderly patients with a lot of issues, volume depletion, hypotension, and other comorbidities. Somebody who is prone to orthostatic hypotension is having dehydration and all those things. You want to be careful because you know that UTL2 would reduce or cause some volume depletion in such patients. And a pregnant and breastfeeding woman is not to be used. And type 1, let me say this here, I beg you. I've seen many, and Dr. Tasi asked me to say this. So Dr. Tasi, if you're online, I'm doing your job for you. There's a propensity for some of us to be using SGLT2 for patients of type 1. It is an off-label indication. It's not by the manufacturers, but it can be done under specialist supervision. So if you're hiding in some corner in some village or even Accra, some one-man place, be that the patient's A1C is bad, they can't even afford, and you are adding SGLT because you think you can do other things. Be careful. You may, rather than thinking you are helping the patient, be harming them because it may expose them to the risk of DKA. And in children, you know the outcomes, possible outcomes. So Dr. Tiasi, I've done your job for you. Overview of Synjardy, it continues in terms of pharmacology. No clinically relevant drug-drug interactions has been found. So all the dose ranges, can be used with, they are bioequivalent in terms of the individual components when you combine them. Then PK is affected by food. PK is pharmacokinetics, okay, which is not considered significantly a significant issue. However, as metformin is recommended to be taken with meals, Synjardy is also proposed to be taken with food. I hope you get it. SGLT2 you may take with or without food, but metformin is usually taken with meals or immediately after meals. And because they are combination drug, what we are saying is that take it with meals. Thank you. Again, these are the dose combinations. Jonas will tell us later which ones are available on the Ghanaian market. Okay, and there are a few things that we need to avert our mind to. Absorption, EMPA peaks around 1.5 hours, and then but the pharmacokinetics is not affected by food, as I said. Metformin peaks around 2.5, but it's affected by food. Half-life of EMPA is about 12 hours. Okay, so usually once or twice a day should be fine, but metformin is 6.5. And then look at this will affect why some of the indications. And then metformin is excreted entirely unchanged in urine. And then there are no active metabolites, as it were. Okay, so these are drug-drug interactions. All of these, there are none, as has been demonstrated. So again, to summarize the pharmacology, is indicated for treatment of type 2 in adults 18 years and above as an add-on to metformin alone, or metformin combined with other drugs, glucose-lowering agent, and also as an alternate to existing combinations, a combination of EMPA and metformin as separate tablets. Okay, the kinetics, as I explained, there's bioequivalence of the individual components, and it's not associated with clinically relevant drug-drug interaction. And we say that though food marginally affects its effects, we still insist that or advise that it be taken with meals because of the metformin. And then Synjardy is rapidly absorbed with peak concentrations reached within 2.5 hours, and there are no major metabolites. And the drug is eliminated in feces and urine. And also, because especially SU, they can prolong QT. So what the evidence suggests is that Synjardy doesn't. So some clinical data will be running up shortly. So this is showing, the clinical efficacy of Synjardy and the studies that has been done or have been done, and that is what brought out the evidence to suggest the claim that we are making today. Okay, so as monotherapy on top of metformin, or as an add-on to an existing dual therapy, add-on to existing triple therapy, and as an add-on to insulin-based therapy, either as to basal insulin or an MDI. All of this, Synjardy have shown efficacy and good side effect profile. Okay, so we'll move on. So some of the secondary benefits that you ought to know. So we are comparing metformin and SGLT2 as the components of Synjardy versus some of the molecules that you are aware of. So glucose control, hypoglycemia risk, weight loss, blood pressure reduction, and lipid profile. So metformin ticks a lot of the boxes, good for glycemic control, low risk of hypoglycemia, and then is weight neutral. Then SGLT takes even more. It also reduces blood pressure, but you are aware that DPP-4, apart from lowering blood glucose level, is weight neutral. Pioglitazone, I have seen patients who are put on weight of pio, so I'm not entirely sure that I agree with this, but blood pressure reduction have been seen sometimes, and again on lipid is weight neutral. And so for now, you see where they are. If you look at the guidelines, they push SU some, but they forget that Charlie, Allah. Okay, it's like those days when we're treating TB patients. They said never add a single agent to a failing regimen. Yet the WHO guidelines recommend adding a single agent because they have to pay for it. Okay, so EMPA as and EMPA and metformin as initial combination therapy in type 2. So it has shown, effects. So this is expanding on the other this thing that I spoke about. So it's telling us about this is 5 milligram EMPA, with metformin 500 BD. This is just metformin alone, and it shows, from baseline a clear difference. And this is increasing the dose of metformin, and then comparing with metformin alone. So depend on the dose ranges of variabilities or combinations that you have, it still will show enhanced benefit in terms of glycemic control. And then this is looking at the baseline medications, and as you add on other EMPA or EMPA combined with metformin, what the impact is. And then on top of metformin, these are the difference. So this is EMPA 25 and EMPA 10. So compared to PIO, with the background, if you added this, you are going to get more, increase and enhanced reduction. Metformin and SU, if you compare with this one, it's better. And across all the ranges, okay, in terms of glycemic control. And then you're looking at a proportion of patients who were achieving A1C less than 7% when you use the combination compared to baseline therapies. And again, across all the ranges you saw, other metformin alone on top of PIO, MET-SU, and all the others, it showed clear benefits. Then what about weight gain or weight loss? Again, by the addition of EMPA to these baseline medications showed clear benefits. There was a little discrepancy here when the 10 rather did better on multi-dose insulin therapy. Otherwise, but if you combine the two, certainly compared to baseline therapies, in terms of weight loss benefits, EMPA combination with metformin did a greater job. Okay, so this is like a summary again, and it says that metformin combined with EMPA significantly lowers A1C across a number of different background therapies, allowed more patients to reach their glycemic goal, which I showed in the previous slide, compared to placebo, a comparator group, and then provided significant weight loss versus placebo active comparator, and lower systemic blood pressure across a range of background therapies. Let's look at tolerable issues. And then again, this is some side effects profile that you can see. So look at this one, major hypoglycemia. So this is placebo and metformin 0.5. This is Jardiance's 10 with the component of EMPA 10. It's similar. And then the 25 didn't even show. UTIs slightly higher with the 10, and then lower with the 6.6. Then genital infections, that was clearly higher in all those ranges for EMPA. And then increased urination, of course, you expect that because of the mechanism of action, and the osmotic diuresis will result in increased urination. And then volume depletion certainly is also higher with the EMPA-based medications. So in terms of tolerability, let me summarize that as well. And a low incidence of major hypoglycemic events, increased incidence of UTIs with EMPA 10 versus 25 or placebo. Then increased frequency of genital infections compared to placebo, certainly, which is because they are exuding glucose around the genital area. So that is why it is important to maintain good genital hygiene, especially with our ladies, But usually when you treat them, they tend not to recur, okay? And then you also had lower numbers of volume depletion events similar to placebo, and a higher frequency of urination, which is a given, isn't it? So just to recap the recommendations. Okay, so it's efficacious combination in a single pill with flexible dosing options to individual treatment. I'm sure Jonas will talk about that, what is on the market, and a convenient single pill combination for your patients. And again, a recap as we prepared, I prepared to sit down. Again, EGFR less than 60, you should be cautious or not to use it at all. If you are pushed, you may go up to 45, but it has to be really, really under close supervision. The patient with hepatic impairment, alcohol intoxication, or alcoholism is not indicated. An elderly patient with the risk that I spoke about, especially with the tendency to volume deplete, hypotension to static hypotension if they are on loop diuretics, you need to be careful. And the patient with type 1, Dr. Tiasis a caution, and then pregnant and breastfeeding women, you don't have to use them. So these are the convenient dosing approaches. So 5/500. If you use it twice, you are getting EMPA 10. This is 1,000. If you are using this, you are getting 10, 1,500. If you are using this, you are getting 10, 2,000 as dual or 2 times daily medications. And you can increase as appropriate to achieve a maximum dose of empagliflozin at 25 and the maximum dose of metformin at 2,000. But if you are using the 850, that will give you about 1,700. And then when you are switching from individual components, if somebody is on metformin already and also EMPA separately, you use a combined dose to achieve the same EMPA dose. And the metformin too, you have to do same. But sometimes you can reduce the basic just to be sure that they are not having any issues. And Synjardy should be taken with food. All right. This is a slide I put in, but I won't talk about it because Dr. Nikwe has done a better job than what this slide says. So what are the take-home messages? 1, it offers Synjardy dual mechanism and superior glycemic control with loss. We demonstrated that. Blood pressure reduction, we showed you the data, and low hypoglycemic risk. We also showed you the information. And these are key unmet needs in the management of type 2 diabetes in this country and even at the worldwide platform. We also are aware, and we've shown the information, that single pill combination improve adherence and simplified regimens, which is a major barrier to achieving glycemic control or our targets. Synjardy is effective across the treatment continuum, from monotherapy to insulin-based therapy, even basal insulin or multi-dose injections per day. And it's ideal for patients who have not adequately controlled on metformin alone or require an add-on therapy without weight gain or hypoglycemia concerns. But however, you have to use it at an eGFR equal above 60. 60. Danke.
Thank you very much, Professor York. Before we move to the official launch, or whatever you can call it, it's question time. So if you have any question, both the online participants and those of us here, you can please probably lift up your hands, and then both speakers are here, and then we do justice to any question. So I don't know whether Kevin and the crew can help us with the questions online so that we will address them adequately. Thank you very much. Any question, please feel free. Let's dialogue. Any question? Should I start from here? Dr. Jumana, any question, please? Thank you. She has a question, you see. That's a trick. I've always learned those tricks.
Very much. I've been using Synjardy for the past 3 years. So when you told me that you're about to launch, you remember I laughed. I was like, how come? Because we've been using it for quite a while. But it's been a very great program and presentation. I was finding out about the 5850 because I have a client who has been on it for 2 years plus. He's achieved glycemic targets and he's doing very well. And I've tried switching him because I'm not able to get the 5850. Ray will attest to it. He's gotten up. So they said it's been discontinued, or maybe I didn't get it right. Yeah. but he's adamant. He's used to that dose and he wants to continue.
Thank you very much. I will answer this question. In fact, I will put it in the fridge and I will open the fridge and then address those issues. Any question on this table? Please feel free. Ask any question at all. But we are talking about diabetes. So please, any question? Sir, do you have any question? Feel free. Yes. The way you are looking at me, it appears you have something. Please, those of you, any cardiologists here? Where is Dr. Tego? Please, do you have any question? You don't? Or you think if you ask Professor York next week, Friday, he will trouble you? So you are okay. Very okay. Any question? Please, any question here? Are you okay? Well, I presume so. Any question, please? You know, let me tell you this. I used to have these trainer way back, many years ago. He sits in the UK. You know, the Americans are, they are not like the Americans are not like the guys from, you know, the other side, you know, the UK, you know, it's like, it appears the English is a bit more polite. And you know how the Americans talk. And this guy is from UK. And one day we were in a meeting and everybody wanted to ask a question. Spring was there. And then the guy realized that nobody was talking. Then he said, look, no question is a stupid question. Ask your question anyway. We are here to learn. And I was surprised. Apparently, people were sitting on a lot of questions. And we learned a lot when we started talking. So please, don't think that your question is not relevant. It is. Because you see the patient. And I believe that if some of these questions are adequately addressed, tomorrow morning, you see a patient, say, this is what Professor York or Dr. Nikwe spoke about. So please, if you have any question, feel free and ask your question. Ask your question, please. For the last time. Yes, the online participants, please, any question? No question yet. Okay. All right. So let me find out from my colleagues or my senior colleagues. Mr. Jaku, please, do you have any question?
I don't have any question, but what I want to say is that the product is available. We have about 3 distributors that who make the product available from us, DP World. And anytime you do prescribe, you are likely to find what you want for your patient. Right.
Thank you very much, Mr. Yao Ejaku. Thank you so much. Any question or any? Right. Everybody is silent. Okay. Everybody is tired. If that is not a case, then it means that the information is loaded, is rich, and all your fears and all your questions have been addressed. The online, they said, it's still no question online. You are sure? Because tomorrow I don't want my reps to be queried. That when you launch the product and we ask questions, nobody address it. So if there is no question to that effect, I will please humbly invite Professor York. Sir, please come forward. Please kindly put on the light for me. No, to the other side. The other side, no, the switch. Yeah. Thank you. I would also like to invite Dr. Nikwe, please. Thank you. I will also invite Mr. Yao Ejaku. Please. I would also like to invite George. They have a simple tax. Very, very simple. I have some gold bar here. Unfortunately, these gold bars, in fact, I wish I have about thousands of them. But I will please ask that you unwrap it. They are going to unwrap these gold bar. This is not men's gold, please. I think you pull this one. Yeah. Okay, so I will hand over the microphone to Professor York to tell us what he has in his hand and what Dr. Nukwe, if it indeed is the product why we are here, what are his takes? I know he has spoken a lot, but should we go ahead and get them for our patients as we see them? Prof.
Thank you, Jonas. What I have here, ladies and gentlemen, in my hands, it's Synjardy, which is a combination molecule of metformin and empagliflozin. The dose of empa is 5 milligrams and metformin is 1,000 milligrams. So what it says on the box is that it's film coated. The pharmacist will explain what it means. And it is produced by Boehringer Ingelheim. And this is certainly a medicine that you can use twice a day for your patients. For the stated benefits during the presentation this evening, we said that it offers simplicity in the dosing and convenience, and is efficacious on glycemic control. It is also positive on your blood pressure reduction, your weight loss, and also hypoglycemia. So it's a wonderful drug that we are adoring today. Thank you.
Okay, I have the higher strength, 12.5 versus 1,000. The benefits, as Prof mentioned, I would add maybe 2 or 3. Renal protection. It reduces albuminuria, slows down EGFR decline, heart failure indication, and then patients with ASCVD or high risk for CVD. So these are the benefits of the combination medication, especially empagliflozin manufactured by BI in this combination.
So on behalf of BI and DP World, and on behalf of the executives of these two entities here, and on my own behalf and that of Dr. Nukwe, and on your behalf, those of us on online, signed on online, we declare officially the product Synjardy, which is a combination medication of empagliflozin and metformin, duly launched in Ghana. So what from us, we wish the manufacturers and the promoters of this medication is that we hope it continues to do well and even surpasses what the initial uptake has been. As she said, it's been using for about 3 years, but this is the official wedding ceremony. They were engaged, but not married. Now we are married to Synjardy, and I hope that all of us will find its use at the appropriate, if we select our patient rights from what Dr. Nukwe and myself have told you tonight. And if you have any issues, get back to the reps of DP World and BI, and I'm sure they take care of your concerns. So thank you very much for coming.
Thank you very much, sir. Thank you very much. Please, you can have your seat. George, please stay back. Kindly help us to throw one or more lights on Synjardy, please. The SKUs available and so on.
Thanks, Jonas. I know one of the questions was the 850 milligrams. So in Ghana and generally within our region, what you will have is the 12.5 1,000 and the 5 1,000. we had the 12.5850 and the 5.850. Unfortunately, because of SKU rationalization and all these other things, we are not able to have the 850s in the market. It is unfortunate, but I think it's important we tell you the truth so that you can be able to see how else you can be able to see how your patient can benefit from. They can get the Jardians and then they can get the metformin. It would have been nice if we had the 500, but unfortunately we also don't have it. Having said that, I would want also to take this opportunity to pass the vote of thanks. First and foremost is to appreciate Prof. York and Dr. Nikoi for the excellent talk. We don't take it for granted. We appreciate your time, the time you've taken to prepare, and also the time you've taken to be with us. As Boringa and DP World, we really do appreciate it. I also want to take this opportunity to appreciate the audience, both physically and online. There were many other places where you would have been this evening, but you have chosen to be with us. We do appreciate that. I also want to appreciate Jonas and his team for putting up this event. I know it has taken a lot of hard work. I'm sure you have seen a lot of reminders telling you and calling you to be here. So I also want to appreciate that. DP World, our partner, like what was said, we cannot have this medication without them being and without them doing what is required of them. So we also do appreciate that. And lastly, we have our partner who is CES. I know they do an excellent job. I have been engaging them, but today I've had an opportunity to see them. And maybe something you don't know. If you look at south of Sahara, north of Limpopo, if you look at an organization that does an excellent job as far as the online platform is concerned and the attendance, it's CES. So I would really want to appreciate them for that. They do an excellent job, and I know we'll continue engaging them. You will always see Boringa, our webinars where we engage them and they circulate the link to you. So it's an organization that we hold dear and we value their input. Having said that, I know our sugars might be low, so I think it is only fair we do something to push up the sugars and to invite you for the dinner. Thank you.
Thank you, George. So thank you so much. We are done for tonight, but we are not done for the meal. So please, let's sit appropriately and please enjoy your meal. Eat as much as you can, please. Just sin for tonight and tomorrow repent. But perhaps if you have a problem, you can see me for a pill of Synjardy, like Prof said. Yeah. So, Dr. Jumana, don't worry. Like George said, we are no longer bringing, because it's just for a niche, few people or patients. So it becomes a bit of a challenge, but
you.